Welcome to our symposium, Precision Medicine, Advancing Sleep Apnea Phenotyping Through Accurate Flow Measurement. It's so nice to be here with this full room in beautiful Singapore. So at Nox Medical, our mission has always been to push boundaries of sleep diagnostics, not only to capture signals, but to capture them with the accuracy and fidelity needed to truly transform patient care. We believe that accurate flow measurement is more than just a technical achievement. It is the foundation for understanding the mechanisms of sleep apnea, enabling phenotyping and ultimately moving towards personalized precision medicine. That's why we've organized today's session to bring together global experts from research, clinical practice, and technology to discuss how better signals can lead to better science, better decisions, and better outcomes for patients. It's my great pleasure to introduce our chairs for this session, Professor Fang, a man that needs no introduction. He is known worldwide, but again, a few words only. He is a professor of medicine, chief of the Department of Sleep Medicine in Peking University People's Hospital, with his major research interest in respiratory control, in sleep apnea, and genetics of narcolepsy, and also Professor Liang Han, director of the Sleep Center at China Medical University Hospital in Taiwan, former president of the Taiwanese Sleep Society of Sleep Medicine, and for the last couple of years, his major focus has been endotype analysis of obstructive sleep apnea, where he has been publishing extensively. So together, they will guide us through an engaging session that will hopefully sparkle some discussions, ideas, and collaboration. Welcome.
Yes, thank you, Nox Company, and especially Currents, to give us the opportunity to get together to share some new knowledge about this personalized in sleep apnea diagnosis and management. I would like to first introduce my co-chair, Dr. Huang Liang from China University, Taiwan, and he would like to give a brief opening address. Please.
Thanks, Professor Fang. And to be honest, I'm very grateful, thanks this opportunity to be here to talk, to discuss with all of you interested great change from the OSA diagnosis, from phenotype to endotype. And my co-chair is Han. Truly, he's my teacher. I come to Pathophysiology to study medicine. He gave me a lot of the talk, not only narcolepsy, and also the spleen disorder. So I'm very honored to be here. And also thanks Nox organize this symposium. Actually, to be honest, I do the endotype analysis for 5 years before pandemic. But this is my first time to have the time to listen to, including my friends Scott and John, and my colleagues then together to talk about how to redefine the polysomnography with the endotype analysis. Then I will shift to my co-chair, Dr. Han, to introduce the first speaker. Thank you.
Thank you. Please, our speaker on stage to sit here. I think, yeah, please come. And I would like here to introduce the first speaker of Dr. Ágústsson from, I think, the Vice President of AI and Data Research at Nox Medical, where he leads the development of this artificial intelligence and data-driven technology for sleep diagnosis. Yeah, please. Yeah. Yeah.
So sorry, sir. Is that you?
Yeah.
Okay, this quickly is forward and reverse. is forward and this pointer.
Okay,
Thank you.
So thank you all for coming. Today I'm going to talk about why measurements of flow in sleep studies are important. I'm going to start with this figure that I got, I think, from Scott Sands. And I really love this figure because it shows two flow traces from patients with sleep apnea. And what is obvious when you look at these traces is that these two patients, they don't have the same kind of sleep apnea. And I thought this could just be the end of my talk. Yes, it matters to measure flow because then you understand what kind of sleep apnea your patients have. But I was at a sleep meeting in Seattle in June, and I got this question from a sleep researcher. How do you measure breathing with an oximeter? I was like, I don't know. So I went digging into it, and I mean, we've heard talks during this conference. There's a lot of physiology that how breathing influences the cardiac output and heart rate and everything else. And these are things that you should be able to pick up in an oximeter. But the thing with the oximeters, and I always like to highlight this, I'm an engineer by trade, so I have to always go to the technology, is that they are designed to measure the SpO2 in a steady state. So not even the transient dips, but in a steady state. And when we start to do things like breathing or something else with these oximeters, we're really going beyond what they're specified to do. And the performance varies between oximeters and may not be exactly how we think it could be. But the question I was thinking, like, why would you want to measure breathing with an oximeter? And the typical answer we get from this is that in a sleep study, measuring breathing accurately is really, really difficult. And what we use in many sleep studies is maybe a nasal cannula or something like this. And it's sensitive to breathing up to a point. And there's great work by Pedro Genta in Brazil, where he's having people sleep with an oronasal mask. So it goes over the nose and over the mouth. And it's separated. And he has a pneumotachograph, and he can measure very accurately the breathing through the nose and the breathing through the mouth. And here we see one example. So there's a patient that has sleep apnea, and is not breathing. And then starts breathing, and we can see that most of the breathing is through the mouth. Just a bit of the breathing is through the nose. And I think this is something that we all intuitively know, that when we don't breathe for a long time, typically the first breath is through the mouth and like a gasp, and not through the nose. And we've looked through a few studies and plotted the ratio of oral and nasal breathing as a function of breathing. So normal breathing tends to be through the nose, but obstructed breaths tend to be through the mouth, and really big breaths tend to be through the mouth. And when we measure breathing with a nasal cannula, we can get something like this. So here we see an example measured with an oronasal pneumotachograph in the blue, and the same breaths measured with a nasal cannula in orange. And what we see is that the recovery breaths, which we know tend to be through the mouth, they are underestimated when you measure them with a nasal cannula. And if your goal is just to count apneas and hypopneas, it's not a problem. I mean, you will get the same number of apneas and hypopneas with this measurement. But if your goal is to understand what is causing the sleep apnea in the patient, to try to make a decision what is the best way to treat them, then having an accurate measurement of the flow can be very important. And I think Dr. Sands and Dr. Chang will go more into detail on that. At Nox, we are really invested in respiratory inductance plethysmography, or RIP. And I really want to spend a bit of time on this, is that respiratory inductance plethysmography means something very specific. Typically, when we talk about RIP belts in a sleep study, people think about respiratory effort, and they use them to see if the patient was trying to breathe or not. But at Nox, when we talk about respiratory inductance plethysmography, we are very specific. We're talking about respiratory, measuring breathing, and we're talking about inductance. And that's a key word, because when you measure inductance, the inductance changes in a direct relationship to the changes in the volume of the chest and of the abdomen. And the changes in the volume are directly related to flow. So measuring inductance gives you a measurement that's directly related to the flow or to breathing. If you have other types of effort sensors, like a piezo or a strain gauge or something else, the measurement that you're doing may not be directly related to the flow. So keeping this in mind, we can start thinking about how do we get a good flow signal from rip sensors. And in this picture, the rip sensors are the white belts on the man lying there. We published this paper a few years back. This was a great collaboration that we could have with Icelandic University Hospital there. And what we were comparing was the reliability and the quality of different flow sensors. So we had nasal cannulas, and we could see that the nasal cannula, it tends to come out of the patient. It's not really bad, but it's not very reliable. And then we had 3 types of rip belts. We had what is called cut to fit. So this is an old type that you could cut and make clamps of. And what we saw, that this belt tends to break. We had another one, which was a semi-disposable type that you could put in a washer and use again. And this was also a rip design that was also a little bit unreliable. But in the rip belts that we use today, which are these snap-on belts, it was actually a little bit troublesome making this figure because all the data is just scrunched up there in the same place. And these tended to be the most reliable sensors that we had in the sleep studies. We also looked at quality. And what I mean by quality is that if we take the rip signals and create a flow signal for them, does it correlate with actually the measured flow signal? And what we saw was that in the cut-to-fit belts and the snap-on belts, we had rip signals that correlated well with the flow signal, and in the semi-disposable belts, there was very little correlation. So what we learned from this is that it's not only measuring rip, which is important, but actually the quality and the design of the rip belts really dictates the quality of the flow signal you get out. I'm going to show you a few examples of rip flow, because once you have a good signal, you're not all the way there. And this is from a paper that is being reviewed, so hopefully it will be published at some point soon. But what we have here is just comparing different ways of extracting flow from rip data. The black trace up here is just what we call uncalibrated rip flow. So you just take the signal from the abdomen and the chest, you add them together, and you get a flow signal. And the blue trace here is oronasal pneumotachography, so really the most accurate measurement of flow that we could have. And what we see is that during the apnea, the rip flow signal still shows some spikes. And the reason for this is that if you just add the signals from the abdomen and the thorax together, they don't cancel exactly during the apnea, so you have this residual movement. We have introduced a calibrated rip flow in our product. And when you do the calibration, so this is calibration that just runs over the night, you don't have to do anything special, you get a better visibility of the apnea, but there is still a little bit fuzzy in the signal. So what we're introducing in this paper, and we haven't introduced in our product yet, is an improvement of the rip calibration. And in this, we can actually get a much clearer picture of the apnea. And what is also important for us is the amplitude of the recovery breath is more closely related to what you see in the oronasal pneumotachograph. So this allows us to get a signal from the rip flow from the rip signals, which tracks much better the oronasal pneumotachograph. So actually, if you can do this, you just have the 2 belts, you can measure breathing like this. Now you have something which is not difficult to wear and can actually give you very good data. So I'm just going to come back to this figure. So before we had the blue signal, which was the pneumotachograph, and the orange, which was the nasal cannula. And now with plot in the green, the rip flow signal we get, and we see that it tracks much better the oronasal pneumotachograph. I'm going to end here, and give it up for the other speakers. Thanks.
Yes, thank you. I think we'll have a question afterwards, right? Thank you for this, very good talk about this classical technology. monitor sleep and breathing. Actually, any physiologist of respiratory physiology knows that, but then only Nox make the modelize. You know, AI, we need good data. So this is the tool. And the second speaker would be Dr. Fang. Yeah, please. Yes, we all know that Dr. Fang was a rising star in this area, but now get established, still rising. Yes, he's the person to let us to know what's the mechanism behind this phenotype. He's from that very famous phenotype group from Harvard University. Please, Dr. Fang. Yeah.
Great. Thank you so much for the introduction. It's a pleasure to be here. I'm excited to talk about this. I've got some new data to share as well. So, yeah, thanks also, Jon, for the excellent introduction. My disclosure is that I consult for Nox, which has made us some great friends and some great collaborations, and I hope to continue that, the work we're doing together for as long as possible. But here we go. We've got, the motivation for why we're interested in measuring flow nicely is that we think we can get more detailed information about why patients have sleep apnea. And that's not just for fun. I mean, it's fun for me, but also, we're motivated by the fact that not everybody responds to different therapies in the same way. And we think that that might be based on the underlying physiology. So here is an example from the supplemental material of a New England Journal paper, now a little bit old now, but looking at some patients respond very well to a therapy called hypoglossal nerve stimulation that we'll all know in this room. But others don't respond very well. And maybe there's some differences in underlying physiology there. And as a step, we're not necessarily going to jump straight into perfect prediction, like you are going to respond well and you are not going to respond well. But there's a step in between that we've been calling stratified precision medicine, where maybe we can identify one subgroup of people based on a collection of information about their underlying causes of disease. That will respond better than others, or get some risk. You have a 60% chance, you have a 40% chance. So everybody in this room is probably familiar now with OSA pathophysiology traits. We've got 4 things that we talk about in terms of causing sleep apnea. The collapsibility of the airway is always number 1. We also have loop gain, muscle effectiveness, and arousal threshold. And there is just a wealth of data from physiology studies supporting their contributions to sleep apnea. So I'm not going to try and go through all of that information. We're going to jump ahead and talk a little bit about how these kind of interplay and why we don't necessarily expect all the treatments to work equally well in everybody. So this is our conceptual framework for how the traits come together to cause sleep apnea. We have a collapsible airway that's limiting airflow, and we've got an upper airway muscle apparatus, different upper airway muscles, protecting against the airway, but they don't just fire spontaneously. They have input from the hypoglossal motor pool, the palate muscles, that's influenced by ventilatory drive, the intended ventilation, and that there's inputs from the amount of ventilatory drive come from the chemoreflex control system, and a low arousal threshold puts an upper limit on how much ventilatory drive and how much stimulation you give to the muscles. And so the complexity here, you can see that if different people have different levels of muscle effectiveness, arousal threshold, and loop gain, then we may not expect them to do quite as well with different therapies. So I've shown, Jon showed a really nice example of how people look different. I'm going to show you a couple of examples of how patients look recognizably different. So on the left, we have an airflow signal at the top. This is an oronasal signal, and underneath the ventilatory drive signal from diaphragm EMG that's usually missing on a sleep study. But what you can see here is a person with a moderately collapsible airway, so a kind of normal-looking respiratory drive. They have an okay airway. They're not that flow-limited. And as they build up respiratory drive, their airway gets worse. And so their sleep apnea is caused by their moderately collapsible airway paired with a low muscle effectiveness or poor muscle response. And their loop gain and their arousal threshold doesn't matter at all. So if their loop gain was higher, they would still deteriorate just a little quicker. Here we go. Their ventilatory drive would just build up faster and they collapse faster. But here's another person, and about 60% of patients look like this, or a little more like this. We have a highly collapsible airway in this patient, and that's offset a little bit by a good muscle effectiveness. So as their ventilatory drive starts to go up, their airflow starts to make a comeback. But they also have a high loop gain and a low arousal threshold, perpetuating cycling. So, these 2 patients look different visibly. You can see on the left you know, we've got this descending pattern and a surge, and here we've got a little bit more like a periodic breathing, quasi-central sleep apnea version of obstructive sleep apnea, right? And we should be able to recognize these things from a PSG if we measure airflow. And just to give you some little extra bit of evidence of that, we have, you know, a computer-simulated version of sleep apnea. I'm showing you here, this is what our computer system will give us if we give it a low muscle effectiveness and a milder collapsibility. And if we give a higher collapsibility and a normal muscle effectiveness, we get kind of similar patterns to what we see in our patients. So there's an underlying basis for these patterns that we can see that are different between individuals. And the key thing here is you can see this by eye. You don't necessarily even need a fancy analysis to do that, but you know, nobody's going to be judging their sleep studies in detail like this in the real clinical world. So what we've been doing, and this is now 10 years old now, is to take an airflow signal and a PSG and try and get a measure of the underlying traits causing sleep apnea to get our, you know, our physiology out of the specialized laboratories and closer to being in the real world. And so what we do, we've taken our airflow signal here. This is the caveats that it's a nasal pressure cannula, so it will have the challenges that brings with it. But we generate a ventilation signal from that nasal pressure airflow. You can see there's the surge in ventilation, and here are the respiratory events. And we fit a mathematical model or a physiologically constrained model that is similar to where we get a ventilatory drive response for whenever flow goes down, right? And the idea is that whenever the airway is open, or at least more open, we have a ventilatory drive signal or a chemical drive signal that will track or fit the recovery period, right? And so the higher the loop gain, the faster this will rise, and the greater the overshoot you will see. And so we get a measure of loop gain off every little period of the night. But it also provides a ventilatory drive signal or an intended ventilation signal. And from that, we can estimate the arousal threshold. We can look at what chemical drive is at the moment before ETEG arousal and add that up and take an average across the night. And we can also get an estimate of collapsibility. And we define collapsibility as what is the level of ventilation at normal ventilatory drive. So how much airflow you're getting when you're normally trying to breathe. And then what level of ventilatory drive do you get when you try and breathe harder? So in this case, as effort goes up and time has passed, drive goes up, but airflow is not going up. So this person is losing airflow as drive goes up, a little bit like that person I showed on the left. And so do we have a clinical measure of ventilation? We started for a long time with nasal pressure. And so all the data that we have on traits is based off nasal pressure so far. But I wanted to show you what this looked like. We recorded nasal pressure and oral nasal ventilatory flow at the same time, and with all the caveats, if there's not too much mouth breathing, they track very nicely against each other, with the exception that respiratory events are a bit exaggerated in nasal pressure. So we've got this extra reduction in flow in nasal pressure. So whenever you see a 30% reduction in flow, that may not be an actual 30% reduction in real flow. It'll be a little shallower. So we transform this data. So we take our nasal pressure signal, instead of allowing this kind of nonlinear, untransformed relationship, we transform nasal pressure with a power law function. We get closer to a line of identity and an absence of bias in terms of big breaths and small breaths. Now, one of the main problems is that nasal pressure signal in the real world is actually often terrible. Okay, so I'm showing you an awful example of nasal pressure. I hope everybody agrees that this isn't a nice signal. But this is off I'm not going to disclose where this came from exactly, but this is a standard in laboratory clinical trials in sleep apnea. So our therapies that are approved for sleep apnea, they're often coming from data that looks like this. We've got high-pass filtering that's distorting the waveform shape. We've got clipping, and we've got smooth signals that's hiding the flow shapes. So here's just an example of what happens with this little section here. We've got each of the big breaths. You can't tell how big they are. We've got the baseline. The zero flow level is wandering around because of high-pass filtering distortion. It doesn't meet any ASM criteria that's ever been made, right? And then here's a nice signal. So we've got good data and bad data all mixed up, and we're trying to phenotype off all of this, right? And so to move the field forward, we're hoping to see more of this kind of signal where there's a nice flat zero flow baseline, the waveform shape is preserved, and this is a big concern for us. So next I want to say what we've done with this data. So the data that we have in large studies has all been a mix of this, right? We've got good and bad data all mixed up, and we're still seeing interesting signals. And so one example of this is looking at the STAR trial and looking at HGNS outcomes. This is data from the work that we did with Sarah Opterbeek, and what she found most importantly in this study was the strongest signal was for a low arousal threshold predicting failure of HGNS. Okay, so here we've got a few graphs that look like this. On the x-axis, you've got the apnea-hypopnea index. The y-axis here is the arousal threshold. Red dots are non-responders, and green dots are responders. And we've got this predicted area of response here in green and predicted area of non-response in red. Okay, and so what we can see here is the arousal threshold. If you shift for someone with an AHI of 30 and you raise the arousal threshold from, let's say 105 or so to 160, we shift from being in the non-responder space to being in the responder space. Okay. And there's other factors as well. High loop gain was predictive of non-response, and low compensation was predictive of non-response as well. So if we could put all of those things together, we get an endotype, or a subgroup of people. Okay. Well, it hasn't been validated, but at least in the training data here, and the data that we had available, if you imagined that you could take anybody in this space, the favorable patient, and look at how they would do, this would be a much nicer picture, right? If this is you reran the clinical trial and you had all of these folks, you get a much stronger response than this more unpredictable or inconsistent response in the patients with low arousal threshold, high loop gain, and already having a poor muscle response. So this still, this kind of work needs prospective validation. It's cross-validated results, but without further validation, we can't quite recommend taking patients like that from the traits and treating them specifically, right? So that's the work that needs to be done. Similarly here with the CPAP outcomes in apples. So we presented this again yesterday. This is work done by Andrei Zinchak at Yale with us, and we looked at executive function improvement over 6 months with CPAP versus sham. And the question was, does arousal threshold modify that? So that is, does low arousal threshold low arousal threshold patients not benefit as much as high arousal threshold patients from CPAP in terms of executive function improvement? And in this, that's exactly what we found here. On the x-axis, we have arousal threshold z-score from our non-invasive method, and on the y-axis here, we have our performance is executive function test at 6 months versus baseline, and CPAP minus sham, so sham-controlled data. And the average patient didn't get any benefit, but the patients with higher arousal threshold got a benefit that's consistent with having a morning coffee. We saw that same kind of effect with a secondary outcome of executive function, so it wasn't just one outcome. There was also signals at 2 months as well as the 6 months, so it seems to be early and sustained in the high arousal threshold group that gets a benefit. And there was also an exclusive improvement in sleepiness in terms of taking 2 minutes longer to fall asleep, which is a decent period indicating objective sleepiness improvement with CPAP, but exclusively in the high arousal threshold patients. Again, while this is a large study of 500 people in sham versus CPAP, sham and CPAP, it hasn't been validated again, so there's more work to be done. So we can't quite yet recommend that people exclusively treat patients with CPAP with high arousal threshold for executive function improvement and sleepiness improvement, but we're seeing exciting signs that there's a signal to work with there. But what we have looked at a couple of things now that we've validated, right? So we've got two recent things. One, this is new data. This is a Surmount OSA study. We've all seen this exciting result where we've had a 30 events per hour improvement with weight loss across 12 months. But if you look at the individual data, I'm showing you here in red, this is the people with a less than median response in terms of less than 2/3 response. They still do fairly well on average, but there's a lot of people that very powerfully improve their sleep apnea, right? In green. So if you could just target the people in green somehow, we'd be very excited. Okay, you should go ahead and have therapy. So what are the factors that seem to go into that? So we've done a similar analysis as before, but including here we've put age and BMI in the model, and so we've got a 6-parameter, if you will, picture. But I'll start with the covariates. The patients that are older are more likely to be in our moderate response endotype than younger patients, and heavier patients are more likely to be in the moderate response endotype. than lighter patients that are a bit easier to treat. And then after that, we actually have some kind of interesting findings. Higher loop gain seem to predict success. Worse airway seem to predict success. A lower arousal threshold and greater muscle response seem to predict success. The higher loop gain initially seems confusing, but it also turns out that weight loss improves loop gain, okay, and it improves as well as improving the airway. So those are actually effects that may be targeted by the intervention. So we can then look at that group of people in green and the people in red and say, how well do they seem to do? So we actually did this in only 2/3 of the data to save some for validation. So here we've got what looks like more like an 80% reduction in the green group and more like a 50% reduction in the red group. So it's not like, don't treat these folks. They still get a decent response, but if we could get here, I think that would be a clinically meaningful effect. So we reanalyzed the trial, imagining that we just studied these green folks and the red folks in their separate groups. And here we've got a 24% extra percent reduction in AHI if you're in the strong response phenotype versus the moderate response endotype. Now, what we've never been able to do before is we've never had enough data to actually test again, right? And so we left out 1/3 of the data so that we can intentionally test again with defining the groups as we have with traits and age and BMI. And we see the same result in the residual 33%. So we've now got a validated response. And if we look at this, we still have a significant impact of treatment in both the moderate response endotype and the strong response endotype. But that strong response endotype is significantly stronger and clinically significantly stronger by another 20% plus impact of therapy if you pick the right patients. And we don't seem to see that benefit if we pick clinical variables only. So we seem to need the traits and AHI for prediction, but if it was just the clinical variables, we wouldn't get there. Then finally, I think I still just have time to squeeze this in, but we looked at HGNS prediction in advance, and we did this through, this is our collaboration with Antwerp in a consortium we're calling Aggregated Data for Validating Advanced Non-Invasive Clinical Endotyping, cute name. But so this particular prediction is based on site of collapse from prediction using the airflow shape signal, and here where we really want good quality airflow, right? And the reason for that is because the site of collapse, in this case, lateral wall, laterally directed collapse, you can see on the endoscopy, yields really dynamic within breath changes in airflow. And you compare that or contrast that with this sort of flat top looking pattern that we see in classic anterior-posterior collapse at the tongue base. This is the base of the tongue, the posterior wall. Here's the epiglottis and the lateral walls in the oropharyngeal view. Right? And so we think we can see from the airflow shape what site of collapse is occurring. And we also know from our ENT studies that patients with laterally directed collapse, whether it's CCCP or lateral walls, are both not responding quite as well to hypoglossal nerve stimulation. All right, so we can take features off the airflow signal. I'm not going to go in detail what they are, but the more dynamic kind of patterns that we see rather than the flat tops are effectively separating patients. And we put this in a model compared PSG to DICE and came up with a risk score that says your probability of site of collapse of probably being laterally directed collapse. And that was published in EIJ not too long ago. But now we've been able to apply this for HGNS response prediction. So what we had was DICE data. This first thing is to show you that, yes, actually ENT scored DICE results, lateral wall collapse versus not lateral wall collapse. The 27 patients here weren't doing as quite as well in terms of their percent reduction in AHI with HGNS from baseline, right? But perhaps we can get away with not having to do the DICE. This is our dream here. So we took our airflow signal this is actually, to start with, it's concurrently measured on DICE in as many patients as we could here. We've got 95 patients in the low likelihood of lateral wall collapse from the flat top looking patterns, and here are dynamic looking patterns that predicts a high lateral wall collapse. And again, we see a 60-something% response to HGNS in the right patients, but closer to a 40% response in the patients with lateral wall collapse. And from that, we then took patients from their looking at their HST data from Nox devices with the help of our colleagues, and did a test. Now that we have a prediction model that says patients should respond or not respond, we can put them in a group of yes or no. And what we find is that in the 27 people who had a high probability of lateral wall collapse on their HST, they had a 55% reduction in AHI, whereas we got an 82% reduction in with HGNS in those who didn't have lateral wall collapse on their HST. So we now have a validated model predicting HGNS success from the airflow shape. So I know that was a lot of information I threw at you all at once, but anyway, but what I'm very excited by the major progress that we're making in terms of the use of translational OSA phenotyping to guide patient selection for OSA therapies. I look forward to any questions later. Thanks.
Okay, thank you, Dr. Science. Not only about the mechanism, actually, this clinical use in several of big clinical trials. And I think the integration of this physiology and the new technology together, also we have experience in Asia. And I think last speaker, Dr. Chen Wanjun, is from also the China Medical University, Taiwan, and she will share some experience using Asian sleep apnea population. Please, Dr. Chen. Yeah.
Thank you. Thank you, Professor Hang, for introducing me. And thanks to the outstanding works by our colleagues for the techniques advantage. We have brought this together with clinical experiences in Taiwan. And so I'm showing you have no disclosure. Today I'm going to show you why clinicians should care about endotypes of OSA. And in addition to researchers and engineers, we clinicians should be those who cared about endotypes the most, because as Dr. Sands has given us, that the ultimate goal of endotyping is to provide a precision medicine treatment. So the first question when I entered the sleep medicine field is that what are we treating for ultimately? When the exact pathology of OSA is unknown, many clinical studies focused on reducing the AHI as the primary outcome, and it is still now. But while patients actually they care more about their symptoms, how their symptoms have improved, and a little bit about mortality, and I think mortality and cardiovascular events and other comorbidities are those things that we should care more for clinicians. So as in this study in 2022, it shows that symptoms, as in the left panel, and in the right panel, hypoxic burden, they both predicted the cardiovascular event and mortality much better than AHI. So according to Professor Edwards, we should link between genotype, endotype, phenotype, and treatment when we are facing our OSA patients. And the question is do endotypes link better with observable phenotypes and prognosis better than AHI? And do they provide precision personalized treatment selection for clinicians? And that's the value of endotyping in our patients. So the answer, I think, is individualized treatment for heterogeneous patients, OSA patients, based on pathological endotypes, and to improve their symptoms and prognosis is our goal, the clinician's goal. So we don't have to rely on trial and error, which saves both time and money when treating our patients. So next, I'm going to show you some data that we link endotypes with clinical data in the Taiwanese cohort of OSA patients. And the first thing is the link between endotypic traits and phenotypes. By using phenotypes, well, age and sex are actually in strict sense phenotypes, but they are the readily observable characteristics that we clinicians can capture at the first sight of the patient. And here in our study, we found that in men, older patients who visited the sleep center for polysomnographic study, they showed a higher loop gain than younger patients. And the association was clearly linear. And breathing patterns become unstable at old age, as you can see in by the loop gain data. And these associations were adjusted for AHI, so the OSA severity does not account for these associations observed here. And we also observed a negative association between ventilation at evening drive, which we show here as a V passive, and age, meaning that older patients had a more collapsible airway when they come to the clinic. In regards to arousal threshold, it's generally decreased with age, which is more clear in women, but I didn't show it here. As older people, we all have a instinct that they have very easily awakening sleep, and especially when they have OSA. But in young men, there's a trend that arousal threshold increases with age. Well, this is a very interesting finding, but we haven't been able to interpret it very nicely. And here I show the association between BMI and those endotypic traits. Clearly that BMI is associated with worse collapsibility, as we show also in using the V passive here, and a higher arousal threshold and a higher loop gain. AHI was not adjusted in this model, so it could be related to a more severe OSA, so it is quite understandable that of these associations. The most interesting finding here is that in non-obese patients, as we can see in plot B, in non-obese patients, those have a BMI lower than 30, they have a low compensation compared to those with more severe obesity. Well, this may be due to a high V passive in the non-obese patients. As you can see, they have a quite high V passive value, which presents a low collapsibility of the upper airway. And since compensation in the PUP method is the difference between V active and V passive, so there is a potential swing effect that obscures the differences between them in non-obese patients. Even more, the compensation was a negative value in those patients. And that's a very distinguished characteristic in our sample, that when comparing with Western patients, our Asian patients showed a negative compensation value, meaning that when they are aroused from the respiratory event, they have a very poor upper airway muscle function. And these people, I think they could be a good candidate for treatment that enhance upper airway dilator muscle function, such as medication treatments or neuromuscular stimulation. And in obese patients, their V passive is already very low, as you can see in plot C. So a minimal increase in the ventilation at arousal threshold, which is the V active, would yield a significant compensation. But the actual value was close to 0. And we also checked patients with positional OSA and non-positional OSA, and whether their endotypic traits changed between positions. So in the lateral position, both positional and non-positional OSA patients, they have improved collapsibility compared to supine position. Well, that's understandable. And they also have a lower arousal threshold when they were in a lateral position. And this may have protected them from respiratory events in that position. And supine position-related OSA patients had a worsened compensation, as you can see in the right-hand panel. They have a worsened compensation, which is with a negative value at supine position, whereas non-supine position patients, they do not show such a significant differences. And so the results tells us that when we see a patient with supine predominant OSA, this could be partly due to their poor compensation where they're in the supine position. And here's the study from Dr. Ágústsson that who shows that non-REN-related OSA patients, they have a higher loop gain, and in REN-predominant OSA patients, they have a very collapsible airway. And so from these phenotypes, we can prematurely have a suggestion or implication of the endotypes of our patients before we can precisely measure them in our routine PSG. And next, I'm moving on to how the endotypic traits predict treatment response, and Dr. Sens have given us some very updated data. So I just choose some examples from the literature. For example, for oral appliances treatment response, we can see the interaction between arousal threshold and loop gain can predict how the patients respond to it. In the pink area are patients with high loop gain and lower arousal threshold, and these patients actually responded poorly to oral appliances treatment. And for upper airway surgery response, Dr. Ágústsson and also a team from Taiwan has both examined the endotypic traits before and after the upper airway surgery, and also what endotypes can be used to predict surgical outcomes. Well, we both found that non-anatomical traits, especially loop gain, predicts surgical outcomes, and this is quite reasonable because the upper airway surgery or appliances, they mainly deal with the compromised anatomy. So an unfavorable non-anatomical trait would probably limit the treatment efficacy. And pharmacological therapies are burgeoning. But however, I think there is a current limitation is that we are still lack of studies that recruit patients based on their predetermined endotypic traits. So in current meta-analysis, we haven't have data for their endotypic trait change before and after the pharmacological therapy. So in the future, the research direction will be to randomize our patients based on their endotypic traits in clinical trials and to examine the subsequent changes in endotypic traits and also severity. At last, I want to say something about Pencer's patient-centered care for OSA. Here is a latent class analysis of our patients based on their endotypic traits, and that's in the left side. And the right side, we cluster in by their symptoms. And we can find that endotypic traits, they don't exist independently, but there's a complex interaction between them. So using the cluster analysis, we found that patients with high collapsibility and loop gain, these two traits, they often come together. While other patients, they show low arousal threshold, and they usually have a favorable upper airway anatomy and a low loop gain. And there is a very special group of patients in Asia that they mainly manifested a low compensation, generally with negative values. And when we compare the two plots, you will find some similarities here. Those patients with high collapsibility and loop gain also showed, they have the distribution of their symptoms corresponds to those who have excessive sleepy symptoms. So I think when we are targeting endotypic traits for treatment, we should never neglect the interplay between the traits within each patient, each individual patient. And at present, I think we have still little understanding of how these traits dynamically interact. As in PUP method, actually arousal threshold and V passive and V active, they are they can affect each other very closely. So they're not randomly distributed across patients. So our next job is to identify the interaction effects between them. Furthermore, I think that for clinicians, there are other physiological characteristics. I wouldn't say they are endotypic traits, but they could be quite important in the prognosis and symptoms for patients. And I think these are the sleep fragmentation indexes or sleep quality, which we may be able to derive them from EEG spectral analysis or cyclic alternating pattern. And also another one is autonomic function. We have been assuming that OSA patients would have increased autonomic function because of their fragmented sleep and the pressure, the stress to physical stress. So it is time for us to measure autonomic function and maybe using the heart rate variability. I think these are very valuable physiological signals that would inform more about the pathology of OSA patients. And also, I have mentioned the dynamic interaction and disease progression, how the endotypic traits would change in the disease course. So my summary is that for clinicians, treatment goals, it's time to be extended to beyond AHI and to outcomes that are more relevant to patients. And endotypic traits are closely associated with symptoms and treatment progresses, as in our reports showed. And determining endotypic traits that are modifiable and track their dynamic interactions with other traits will be the future direction of research. And at last, I would like to refer to a recent article published in the Blue Journal, which has listed the research priorities of endophenotyping of OSA, and which suggested that endotypic traits should have clinical relevance, and they should be manipulatable, and they should be detectable. And these three criteria, I think, very well corresponds to the clinicians and the patient's need. Thank you.
Oh, okay. Thanks, Dr. Jin. Wonderful talk about the clinical application of endotype in Taiwan's data. Do you have any question here? Please, microphone.
Hello. Thank you for all the speakers for this wonderful talk. I've been following closely on the development of the endotypic traits and how they apply into clinical practice for long. I'm an ENT surgeon from Hong Kong, actually. And I would like to ask a few questions. First of all, is there a night-to-night variability of the endotypic traits? Because since like the last presentation talked about how the positions affect the different the outcomes of those 4 traits. So I would suspect that there would be internight variability. And second, does some of the traits, maybe not all, I presume loop gain does not move much, but for like the arousal threshold and all the muscle responsiveness, is it dependent on the sleep stages? Thirdly, like, okay, for us clinicians, it's very good that there's a model that it can help us predict and counsel our patients which treatment is suitable for them. But in the end, so would we see a change? I mean, I think so. Like, would there we see a change, or do we have like a mark like how AHI does that? Oh, we can prove it treatment success by changing some of the endotypic traits. Like, do we see an endpoint to this? Thank you.
Yeah, it's a great set of questions. I think we could have another symposium on answering those, but we've had a few studies now on night-to-night variability. I mean, we know that AHI bounces around all over the place, and if it's not caused by changes in the endotypic traits, that would be very surprising. Christian here in the front row and some others Tom Talbot as well had done some studies on night-to-night variability. They kind of seem like they're a little bit similar to the AHI in terms of repeatability, coefficients of ICCs of 0.7 or so. Compensation's a bit weaker. It's already a calculation of 2 different measures of collapsibility, so by definition it's a little bit noisier. That being said, all of the data that we have shown on predicting outcomes, the night-to-night variability is in that area in there is inherent in those measures. So we understand that if we see some predictive value, then it's past the test that at least of night-to-night variability is not so overwhelming that it's making prediction fail. I think, and then changes in sleep stage, for example, was the other question. Sleep stage is the strongest effect of sleep stage. I have a paper that will hopefully make it out there soon, but the greatest effect seems to be on arousability. Arousal threshold changes profoundly between stage 1 to stage 3. That allows ventilatory drive to build up between, from basically normal levels during wakefulness to twofold in OSA, and that changes the input to the upper airway, so it's not inherently less collapsible, but it's less collapsible looking as you go through different sleep stages. Loop gain doesn't change much. It goes profoundly down with REM, but not to 0, maybe a third down. So, REM isn't even a completely loop gain free space. And then I actually completely forget your last question. Oh, no, it was about whether you can manipulate the traits and get AHI to change. I mean, they were the early things we would do. Like, the most disappointing one, and Danny Eckert's in the back corner there, he's tried for years to manipulate the arousal threshold with hypnotics. Maybe with Xyrem or something we can do that, but I think with the standard array, that was the thing I think it was the easiest to do. We're in this world of sleep. We know we can improve arousability, but it turns out we couldn't change the arousal threshold very convincingly. But we have been able to change loop gain with, acetazolamide and oxygen, and that lowers the loop gain signal, doesn't change the collapsibility signal as convincingly. Shane Landry presented a little bit on that an hour ago. And then, most recently, we thought we'd never be able to come up with a drug to improve the upper airway muscles, right? And then, now we have, spin-off companies doing this. So, we have been able to at least change those and change AHI, and whether it improves things for patients and improves the lives of patients is the next exciting question for us. Anything you wanted to add?
Yep. For the clinicians' respect, I would say that is a very good question because, yes, we do observe variabilities between night and even in the same patient between their sleep stages and positions. So this is meaningful to the clinician when we are trying to provide treatment. For example, for atomoxetine and oxybutynin, we still don't know if they will change sleep architecture significantly. And when sleep architecture changes, it could significantly change their endotypes. So this is something that we really have to concern. And when there's a good side of a treatment, there may be some trade-offs that we have to consider, and we have to make sure that overall it benefits our patients the best. Thank you.
So, and I'm Dr. Kuka, and I come from Paris there. And I'm Dr. Kuka, and I come from Paris, and I know Scott. So I want to exchange the things with Scott and Dr. Chen, because I'm an ENT Max Fax based with a background, and I turned to be a sleep physiologist later on. So when you talk about the POSA, so the POSA is a typical, you have to relate to the structural changes, where the obstruction side. The POSA is typically related to the tongue level obstruction. What I see as an ENT, especially, is associated with retrognathia beyond 4 millimeters. This is very interesting point, so that we can discuss some later on. The third, another, yeah. So I'll be a little bit faster. So another one, we are talking about the airflow shapes. Airflow shapes, we talked about the lateral pharyngeal wall obstruction. Usually it's not isolated. It begins with the tongue, as we see an bisolateral pharyngeal wall. Mostly in the obese population, we see that. So in those cases, you talked about BMI and the loop gain. Dr. Sands has done a very good study on that. That is due to the obesity. It doesn't we can't rather isolate the OSA from obese population. It is due to the plant gait they do have. And fourth, I think this fourth point is we have to look into all the structural anomalies also that can play a role, especially when there is expiratory pinching. When there is mouth breathing in patients, I see a bit higher loop gain.
Okay, thank you for your comment. Do you have any questions? Because of the time is limited, if you have any questions, our speaker would like to answer you any question. And any equivalent problem, you can visit the notes box. Because 45.
Do you still have time?
Okay.
So the patient with low arousal threshold seem to pose a big issue. So what do you think? Are the thresholds too strict for this, or are we just going to say that we don't have treatments for use, or are we going to wait for I don't know, orexin antagonists or new drugs for these people? So because at least the MAD, the mouth appliances, they're not that bothersome. So you might think that it might help enough, at least at some level. So should we be looking at some other parameters than AHI perhaps?
Yeah, I mean, I think we have to, I'll try and be quick, but the low arousal threshold patients seem to be not responding to a lot of therapies, but also not necessarily doing better symptomatically with our therapies either, or not getting the improvement we would like, whether it's CPAP or oral appliances or HGNS. Andrei Zinchuk's now got his first R01 to study whether you can add hypnotics to CPAP and whether that makes a difference. I think we still have to understand the mechanisms. And, the other question is, whether that low arousal threshold version of obstructive sleep apnea, whether you should be treating the obstructive sleep apnea or working on the arousal threshold as its own thing, as getting people to sleep better and improve their life, not via sleep apnea. And so that's an open question. I think the field would be interested in seeing where that goes in a couple of years.
I would like to respond to our ENT doctor that, yes, it is a clinician's pain that when we use only collapsibility, that is one metric, but we have no idea of where the level the obstruction is. And I think that's why Dr. Sen is developing that tool to determine where the obstruction is, and then we will have exact information about how what surgical procedure we should perform. Yes.
We might just move on to the last question if you want to ask Luca.
Thank you. Luca Gordo from Sweden. A very short question. We were talking yesterday from the diagnostic crisis, and in many areas we go from polysomnography to polygraphy. Today you showed a fantastic progress now from the research setting into the PSG setting. Do you see the way forward coming from the PSG to even more the polygraphic? Probably Yoon as a technician or as a technical person. Can you answer that?
Yeah, I have an opinion. So I think, my background is in signal processing and AI. So for me, more data is always better. So more is more with data. And I think we should not sacrifice the information we collect for convenience, but rather just ask for sensors that people can use in their home to collect the data we need. So, for example, I've been talking with people about sleep staging and arousals. And for some applications, you may need an EEG to get this information. And then I think for us, the vendors, the challenge is just to make it happen so people can use EEG in their homes. Same with measuring flow signals. I think people complain that it's difficult to measure flow signals. And then for us, we just have to make it simpler, make it accessible. And for all the other signals. I mean, in a sleep study, there was a nice keynote by Thomas Pencil yesterday. In a sleep study, we record the whole human body. And we collect a lot of data. I think we don't use it as efficiently as we could. but we should not stop collecting the data. And I mean, going from Ph.D. to home sleep apnea testing, and then just measuring the data we need for the purposes that we need them.
Okay. Because the time is over, so I should be close the section. And we sense all you positive this different way to care our patient by endotype. And if any question, I think it's a difficult area for the endotype. Maybe you have a lot of questions. You can ask the speaker after the talk and even in the box of the notes section. Thank you.